I'll be talking on donor preparation. So these are the ideals. So it is said that the donor preparation is the first hurdle of Dmek surgery, and in fact 70% of US surgeons use IBank prepared. They always say that they are privileged and maybe spoiled. In fact, EK surgery in US starts in the IBank. They use all this P Dmek graft like pre-strip, pre-stamp, pre-stent, pre-punched and pre-loaded. In India, we do all use, but recently in LB Prasad, they are supplying pre-peeled Dmek tissue. Donor damage during donor preparation is between 1 to 4.3%. There are different methods available in the literature. Some are difficult, but it is the method which are going good in your hand, you practice that. So this is my simple instrument of manual peeling. So I call it Trypan Blue assisted manual peeling. It takes only few minutes, maybe 3 minutes to 7 minutes time, depending on the donor age, and diabetic status is one of the important thing. So first we do a Trypan Blue staining with 9.5 millimeter punch, light punch. Then we peel the other thing. We try to leave the edge of the donor endothelial complex. They use restain it to get the margin, and with single hand you just peel it like that. This is real time, no fast, it is normal timing. So after you take a small hinge there, they punch with 3 millimeter, 2 millimeter, 2.5 millimeter, and then just flip the cornea. You take that lip and soak this part very nicely, put in a stamp. Then cover that stromal hole and cornea flipped back, and normal size is around 8 millimeter. So sometimes 7, 7.5, 8.25, 8.5 maximum. So you peel the whole thing, then stain with Trypan Blue. This staining is maximum 1 minute staining is enough. Then you load into the injector system. Sometimes we use this technique to, this is a very more elegant technique, that you free all the edges of that cartilage all around almost 360 degree, so that your peel is perfect and you do not have any radial tear. So you try to rotate as much as possible. Then when you completed it, you will be very faster also, and you do not have any radial tear in that situation. Sometimes you may find there is a tear is going on, you see there, and you make that tear with a tick sign or Nike sign. So that means that round edge, it will not cause further tear to extend centrally. So that tear has happened, but you don't care for that. Now you go as usual. So donor, as we have published this in number is more than 1,000, and in our series that donor preparation time is around average time is around 7.9 minutes, and the donor failure, as I said, around 4.1%. The overall tissue exchange 21 eyes, 7 tissue damage during unscrolling, 14 tissue Dmek graft preparation failure. This is 1.4% only preparation failure. So we have come across that peripheral tissue is contain more endothelial cells. We come with this paper, and we say that if you do a peripheral trephination, we call it Dmek PD, you give more cells. And we have seen that in this is the central trephination, and if you go in you see right and left side, the peripheral trephination is always give more endothelial cells to the recipients. So these are two data of Dmek PD versus Dmek CD, bilateral, just few months apart, and down the line, you see the endothelial cell loss and endothelial cell count rather in the right eye is doing good than the left eye. So we have published another making Dmek graft in a different way, so that during COVID time, we actually, when there is acute shortage, one tissue can be used for 2 corneas. And we have shown that this, the stromal part can be used for DALK, and the Dmek tissue, we can do that. We can use the stromal part for Boston K-Pro as a carrier. So one tissue, 2 patient was that time was a big concept in us because of lack of tissue. So I am skipping this. These are use of pseudophakic donor in Dmek. That is highly possible if you get this kind of image from your lab, eye bank specular image. Definitely you can, the cell count is showing 2800. So pseudophakia is there. So what? So after phacoemulsification, and you see that you have to stain the endothelial surface first, and then you have to choose which is the. And if you stain the endothelial, it's also exclude the area where it is stained. Stained area means damaged area. You can base site, as we are doing mostly in the peripheral Dmek nowadays, Dmek PD. So we always take care of this thing. So wet lab practice is very important. For few cases, if you do maybe 10 cases, and you will be perfectly doing in this method. And now I am going to the basic steps. Namrata, please welcome. So some preoperative preparation is there. So dilatation is necessary for combined surgery. Initially the surgery will be more like 50 to 60 minutes, and with learning your surgery time will be reduced to 20 minutes only. And you must remember that first few cases you should keep some standby optical quality tissue, so that if anything goes wrong during donor preparation, you can do a dissect also. So that is very important to get a mental boost up. So if you see that case selection in both the cases are almost same, already told, but in Dmek little more careful, because we know there are certain things which do not go as dissect. Donor preparation is only manual by Dmek. Main incision size is 2.8 to 3.2 millimeter. Inferior PI I said mandatory, but I have stopped recently for more than 1 year or maybe 2 years. But anterior chamber during the insertion, it to be kept at a shallower level. Then graft transfer is easy in dissect, but it is difficult in Dmek, mostly by injector. Unfolding easy with the dissect, but it is the most difficult part, and mostly by no touch technique, and you need some asymmetrical mark on DM sites to have right orientation. Then donor centration is easy in dissect. It is sometimes challenging in Dmek, especially with sulcus fixated lens and other little bit anomaly in the anterior segment. Air injection easy in dissect, but air injection again is difficult. You have to go right at the center, at the pupil, and just you do not need overfill the eye, and supine position almost same in both the cases. So main incision site we do, I go little bit post limbal, so I give 3 millimeter incision, so you mark the side port. That is basic. So you can have your regular corneals, and then you have to put suture. I do not give suture, so it is, for beginner it is better to give suture. I give just make a groove, and it is just 3.3 millimeter incision, and you just with a normal keratome I just do that 3 millimeter incision. So astigmatism will be a minimum. So DM scoring is same as, but in Dmek we just keep 0.5 millimeter more than dissect. Dissect, it doesn't matter if you are less or more, but here it is very different. There are different methods you could use, but air assisted technique is the best for visibility of Dmek. Air injection is also important in certain situations like post VR surgery, SFIOL, SEIOL, where you do not like to keep any viscoelastic, when viscoelastic assisted, we do not want that. And also here it's important because we want there should not be any tidbits of DM in the back surface of the cornea. Inferior PI, as I said, you can do YAG PI beforehand if it is a clear case, but you can do external PI. Some cases, sometimes it is required, and you can also do with vitrector. But as I said, as I have learned, I have two catastrophe after a lot of bleeding. I stopped doing PI, and this is the thing. It happens sometimes. You do PI, and after some time you see that there is a oozing and it goes behind. Immediately, though we give air, but it may not be sufficient when the patient is on some anticoagulant, especially when you see that this kind of bleeding happens, you remove air, give air, then again remove air, again the blood will come, so it will disturb the whole surgery. Sometimes you next day we see that black ball hyphema in one of my case. So I did, this is a plain simple course without PI, and this is under topical. Nowadays I am doing topical in most of the situation, and you see this kind of a patient, if you have to talk little more, so you give intracameral preservative-free lidocaine, so that will actually do all the things, and you go with without PI, and I have now huge data of PI, but the size of the pupil is important during introduction. So we do not like to have dilated pupil before injecting the graft. We have little dilatation, and as soon as you inject the graft inside, ask the assistant, floor assistant, to put 1 drop of Mediatic drop, and by this time you are doing unfolding, people started dilating. So your unfolding done, dilation 6 millimeter like that, and you have attached everything right in position. So after that you put 1 drop and go. So when we see the patient after 1 hour, 2 hours or 3 hours, pupil is like 8 millimeters, so there is no chance of air-induced pupillary block. The donor transfer or insertion technique, there are many more. Our another speaker, Rajesh, will come. He will show a lot of methods, but there are a lot of gadgets available in the literature, and we are confused actually. So again, what I believe that some techniques are easy, some are difficult. Some techniques may be better in terms of endothelial loss. Glass cannula may be slightly better than plastic. These are all anecdotal literature report, but probably the principle remains same in most of the cases. Consider the cost and time factor, choose a technique which is consistent in your hand, and then master it. Ultimate goal is ease of unfolding, that means least endothelial cell loss during that unfolding procedure. So I use this simple injector. This is from, still I am using for last 8-9 years. The JJ is still supplying me with the Curtis. So this is simple things in the saline tubing, and if this butterfly Curtis, you can just break it with your hand. You just fit with this, and every day you make a new injector, and you fit it with a 2 cc syringe. BD, this I do not like that rubber, very tight syringe. These are very easy syringe, and you take the graft in the Curtis. So before donor transfer, again repeatedly I tell that clean all the viscoelastics from the bag or anywhere in the AC, clean the blood, clean certain fibrin thread, magnify your, because fibrin thread has caused damage to my 3 grafts. So I remembered that fibrin thread is dangerous, it entangles with the graft, then you cannot open that graft. You have to take that out, that graft is basically damaged. So you have to take a new graft. So fibrin clots and fibrin threads, blood clots, these are very important. Clean the main port and side port, because you are injecting something, you may take blood clots along with it or fibrin thread, and again that cause entangling with the thing. And remove all air bubble before injecting it. So this is a very well man, and he's a good friend of mine. He has a different kind of scroll inside the anterior chamber. But what I see what is the behavior of the scroll outside that, in the petri dish. So I named them that class. We have presented a video in San Francisco also. So it is available in there. So there are different kind of scroll. depends on age, may not be always true with the age, but age is one of the thing, diabetes is one of the thing, past history of diabetes. So we try to see the where is the S scroll, where is the S mark. Accordingly, we try to draw the take the thing in the injector system, and we always inject in bevel down position. But if sometimes that we see that S is just reverse, we just rotate the injector rotate the curtis inside the anterior chamber, then inject it. So it is something like that. So if you see the S stamp curtis, so you see bevel up position, S is reverse. So some kind of situation is there. So you have to see every day and practice it. And if the check the air bubble before, so I will play this video again. This is very important. This spoil the whole surgery sometimes. So if you see that there is a air bubble here, that is the wrong thing. So because it puts the graft again via the main port. So you have to first take that air out, then you have to go for unfolding. And this is also important. While injecting the graft, if you release the, don't come out easily. You release the fluid first from the side port, not happy, again release little bit fluid, again guard the main port with your forceps, otherwise sometimes the graft will pop out from the main port. This is a perfect scroll situation. So if you have a perfect this kind of scroll, you go inside, you can just unfold it with fluid release from both the side. You unfold it, you just centrally fix it, unfold this side, no tapping, nothing. You just unfold gradually. Just release the fluid from both the side port, unfold, and just ironing of the graft to make it perfectly central. These are rare situations, not happens always, but whenever you get a chance, you always take this chance. Then sometimes this is again an example of perfect scroll, like lot double scroll, typical, you see that double scroll. So you see in the curtis what is the configuration of this scroll. Accordingly you plan yourself, guard the main port, little tapping, your graft it open, fix it in the center, I call it pinned it in the center, and then again little bit of ironing and graft goes. Like these are all real time, no fast forward in these cases. So you see that it is centered well, the indication is perfect, and when the centering is perfect, you just injection of air. It is just opposite direction, endothelial side up. This thing you have to check while, so always in the higher magnification you see, it is just reverse. So you have to flip that graft. So I am showing it for demonstration, but when you are ready, that you just inject the fluid from one of the side port, and you see there is slow release of fluid and flip of the graft like this. And once you have done this, your job is done. Again check the configuration of S, and when you are sure, then you center it and then completely unfold it, and then air injection. This is again a tricky situation where this kind of configuration you in the right hand corner, the orientation is good, but you are halfway. So where it is opened, you just fix it in the left hand instrument, whether it is a cannula or a fine iris repositor. I use fine iris repositor, and then you have to shift the graft little bit from to one corner and unfold it like this. These are old videos, that is suture is there and S is big. So S actually now become smaller and smaller, it is 1.5 millimeter now. So when it is done, then again you see that injection, the air, bubble air right at the pupillary area, and dissect, that is not the question, you go inside and put air. So this is another situation. It is, you see that S is reverse. So you can recognize during unfolding, and again same thing, you have to play with fluid only and tap little bit. Here if you put a suture for the beginners, it is always nice. Here you see that S is right, so you stop there and now centrally fix it, and you just, left hand is always fixing the graft so that it should not move towards the any of the wound area. This is a demo surgery I was giving. I was doing in Kolkata, and the live surgery was telecasting in Italy. So everybody was saying that you are perfect, you are perfect. So you inject from the audience. But I thought probably not. And yes, I was not right. So S was reverse. So again, how do you check this? So again, you have to remove the whole ear and again tap. And little bit, this is a kind of TAS patient, so behavior was different. You can see the color of the iris. It is not like our Indian regular color. So it is iris, lot of iris atrophy. Ultimately we did it, but people learned how to take out air, and you have to be right direction. Then ultimately we saw that that curve is like biceps up. That is the saying. And when it is like this, you can again, now you can see the S and it is perfectly okay. So there are many situations like you see and you are fine. Tight scroll is very difficult. This is I remember this is a 27 years old tissue, and it is challenge. Like you do more damage to the graft while doing this surgery, ultimately surgery, but it took almost 10 to 12 minutes to unfold the graft. The more you tap, there will be more endothelial cell loss. You have to remember that. So not much many trap. That is the time where you have to restrict yourself. So I ultimately managed to unfold it, but ultimately the cell loss was more in this particular case. So our saying is that take a graft if it is more than 50 years, it is most suitable. Best graft is around 60 to 65, where the graft will listen to you. Otherwise, other graft may not listen to you. Sometimes unfolding is a fun, like this is a kind of not so flat, it is half scroll. And you see that when I go in, so I call it that unfolding sometime happens. So it is a kind of little bit flatter kind of scroll. It is like this. So there is 50-50 chance of having the same side or opposite side. So you take a chance and it is right. So after that you put, so flat graft. So we purposely choose this kind of older tissue when the case is challenging, especially where the visibility is poor, where there is a complex anterior segment anatomy, so that we know that we should not manipulate much for unfolding. So this unfolding is once, so you have to reverse it. So another movement. But if it is a scroll graft, then multiple tap will happen. So immediate post-op period is very crucial. Keep the patient in the recovery room for 1 to 2 hours. Normally we keep them, then we examine them under slit lamp, sometimes in the operation theater itself. Right to sitting position is very, if you see this kind of fluid level above the PI, or if you dilate the pupil, it must, the fluid level is above the lower border of the pupil, then your job is done. You send the patient to the indoor, and they will stay for 4 to 6 hours, and in the evening, that is our routine nowadays. And if the fluid is like this, you see like this, sometimes we see that because the air sometimes you cannot control in sitting position, so you burp little air. I always use air. Rarely I use C3F8 or other expansal gas. Mainly for rebubbling situation I use. Otherwise air is going good in my hand. So discharge and counsel the patient about the positioning. That is very important for next 24, 48 hours. And then ask the patient. I usually review the patient on day 2, not day 1, because that day probably you will not see the detachment. Day 2 is, by that time 3/5 or 4/5 ear is gone, so you can really detect your detachment. So in summary, in India we have to do lot of EK in any forms. Cataract surgery in CSR is increased now. Last year we have done about 9 million cataract surgery. This is older data. That means every year we need to do around 15,000 PBK cases. For Fuchs dystrophy is there, they are different in different position. Surgical and visual outcome of Dmek is like cataract surgery outcome. As a beginner surgeon, we need to start this wonderful surgery. Thank you very much. Thank you.